Patient is a 65-year-old male with a history of back pain, as well as pain radiating to his bilateral buttocks. His symptoms worsen with upright position and improve when he is lying down. On examination, he was found to be full strength in his bilateral lower extremities, had a normal gait, and no pathological reflexes. His MR imaging demonstrated severe L4-5 central stenosis with associated bilateral foraminal stenosis. His upright flexion extension X-rays demonstrated dynamic instability at the L4-5 region. Based on these findings, a minimally invasive L4-5 TLIF was recommended along with L4-5 minimally invasive laminectomy. Risks, benefits, and alternatives were discussed. Patient was positioned prone on an Allen frame in order to achieve desired alignment. Pressure points were padded, and skin preparation was performed. A registration frame for spinal navigation was fixated into the posterior superior iliac spine. A robotic navigation arm was attached to this registration frame, and an intraoperative thin-cut CT scan was obtained. The sterilely draped robotic planning unit was used to plan the pedicle screw trajectories for L4 and L5 bilaterally. Following screw trajectory planning, bilateral paramedian incisions were made. A navigated drill was used to create a tract within the pedicles. The pedicular screw tracts were tapped, and this was followed by pedicle screw placement using assistance from the robotic navigation arm. Following placement of the bilateral pedicle screws, a tubular retractor was placed in the right-sided incision in order to prepare for the decompression and interbody cage placement. L4-5 laminectomy and right-sided L4 inferior facetectomy was initiated. For orientation purposes, towards the right of the screen is superior towards the patient's head. To the left of the screen is inferior towards the patient's feet. To the top of the screen is medial towards the midline, and to the bottom of the screen is lateral. Drilling is initiated over the right-sided inferior L4 lamina. Ligamentum flavum is exposed as a laminotomy is performed. A transverse cut is initiated through the right-sided L4 pars interarticularis. Once the transverse cut was completed through the L4 pars interarticularis on the right side, a mallet and osteotome were used to disarticulate the inferior L4 facet. This was removed and saved for later graft placement. The tubular retractor was then turned medially in order to complete the laminectomy on the contralateral side. Bone was removed using a high-speed drill. The contralateral ligamentum flavum was removed using a kerrison rongure. Adequate decompression of the contralateral lateral recesses was verified. Attention was then turned back to the ipsilateral side. The superomedial portion of the superior L5 facet was removed using a high-speed drill in order to complete the foraminal decompression. The L4-5 disc space lateral to the thecal sac on the right side was identified. A nerve root retractor was used to protect the thecal sac, and annulotomy was performed using a knife. Rotating shavers were used to initiate the discectomy and to mobilize disc fragments. These disc fragments were removed using Hartmann rongures. Once an appropriate discectomy was performed, the vertebral body end plates were prepared for grafting. Local allograft bone as well as cellular allograft bone were placed in the disc space. An expandable interbody cage was placed into the disc space. The cage was expanded and its position was confirmed with fluoroscopy. The cage was backfilled with allograft and autograft bone. Screw heads were placed on the bilateral L4 and L5 pedicle screws, followed by a contoured rod and set screws. The set screws were tightened to the appropriate torque and the incision was closed. On follow-up, the patient reported near complete resolution of his leg pain and a significant improvement in his back pain. Post-operative imaging showed reduction of his preoperative L4 to 5 spondylolisthesis and appropriate hardware position.